contained.
And it's contained. It does not metastasize. It does not invade direct tissue. It stays with itself. It can still be life-threatening depending where it is.
If it's in the brain and you can't get to it and it
Yes.
continues to grow.
Right. So they're not benign in the sense of, oh, we don't have to worry about them, but they're benign in the sense of they cannot spread, they can grow bigger,
Right.
but they're still encapsulated.
Okay.
Okay, so they won't directly invade the tissue surrounding it. They'll press on it and push it out of the way. The cancer will actually grow into the surrounding tissues, and then the malignant ones can metastasize. The benign can't.
And can they tell it's a benign tumor if they actually see a capsule around it?
Sometimes they have a better idea that it just depends on.
Don't they
on the
I want to say
screen.
they biopsy.
Well, they'll still biopsy, but by looking at a scan, sometimes they'll say, this looks malignant because of the way it looks, but they still need a piece of tissue.
And when they do the pathology,
then they can tell.
but
Yeah.
what do they see different?
It's some of those things we talked about, what it looks like.
On the slides.
The slides, what it looks
The
like.
cells.
They may do some of the testing for different mutations. They'll do things like that. But what it looks like, what the cells look like, how they act.
Okay.
And they can, like you said, they're benign, but they still could be harmful. I know I can't remember who it was, but the tumor was growing, pressing, and it'd be painful.
Yeah.
So, good question. All right, the malignant tumors, omatodescendate tumor, carcin, epithelial tissue, and sarc, mesenchymal cells.
Mesenchymal.
I'm terrible. All right, staging. And there's different staging for different diseases. Process by which the location and extent of diseases are determined. Crucial, you want to definitely know the staging for your plan of treatment. You want to know what you're going to do. Helpful prognostic value, so the patient knows, you know what you're dealing with. Provides a common terminology for healthcare providers and researchers. There is a research out there, you want to know exactly what they have. Uses physical examination, imaging, and lab results, pathology, cytology results, and tumor and molecular markers to assign appropriate stage. This is very important. Elements of staging system, multiple systems exist. Some systems are used for many types of cancer. Some systems are used for a particular type of cancer. So it all depends. Staging systems provide a systemic comparison of clinical criteria and are useful for evaluating patients for clinical trials. Elements of systems, size and number of primary tumors, how many tumors are there, has it spread, site of the primary tumor, lymph node involvement, are the lymph nodes involved, cell type, tumor grade, and metastatic status. I just had, my friend's niece just found out she had lymphoma, and they were checking, they go through multiple tests and staging for different things. Luckily, it just was in one spot. It was weird, it was actually in her cervical area that they found it. Yeah, she was very lucky. Types of tests used to determine stage: physical exam, look, listen, and feel. Imaging studies, x-rays, CT scans, MRIs, PET scans. They can show the location of the cancer, the size of it, the tumor, see if it's spread. Lab tests, blood, urine, other fluids, tissues taken from the body, pathology reports, surgical reports. The overall stages, 1 through 5, sorry. Both numbered stages are used for cancers to describe progression. Stage 0, carcinoma, but it's localized. Stage 1, 2, 3, increase in number, more advanced disease, and stage 4, advanced disease that has spread to other organs. Structural appearance changes, pleomorphism, variation in size and shape, hyperchromatism, nuclear chromatin more pronounced on staging, polymorphism, nucleus enlarged and variable in shape. Kind of like those cells that I was showing you earlier, but they're more specific. They're abnormal chromosome arrangements, translocation, the deletions, amplifications, and anubiology, how do you pronounce that one?
I think that's a typo, aneuploidy.
So I'm like, all right. Cell membrane changes, the surface enzymes that may aid in invasion and metastasis, loss of glycoproteins that aid in cell-to-cell adhesion and organization, production of abnormal growth factors receptors may independently signal the cell to grow and be sensitive to the presence of normal growth factors. Abnormal receptors may activate signals without exposure to growth tumor. This is just basically the detailed of how the cells will change. Here's some more information on the cell membrane changes. Loss of antigens, placental antigens, PSA, differentiation antigens, viral antigen lineage. Now this is important here, the tumor markers, cell membrane changes, clinical usefulness is the tumor markers. You get the specific tumor markers for that cancer. Abnormal glycolysis, higher rate of anaerobic glycolysis making cell dependent on oxygen. Abnormal production of substances that give rise to paraneoplastic syndromes. Syndromes. Cell kinetic growth and division, increased meiotic index, proportion of cells that are in mitosis at a given time. Abnormal cell differentiation, the grade, there's different grades. Grade 1 is well differentiated. Grade 2, moderately differentiated. 3, poorly differentiated, and grade 4, undifferentiated.
Do they do the staging and the grading at the same time?
They can.
Mhm.
I mean, grading is primarily under the microscope. So how much does this cell look like a normal cell? So
Yeah.
the more it looks like the normal cell, the more differentiated it is, so the lower the grade.
Do staging and grading usually, like if you have a stage 1, probably have a lower grade?
Not necessarily, because it's
Mm-mm.
what the cell looks like. And how aggressive does that cell look? So you could have caught it very early and still have a high grade, but be a stage 1.
But it's very aggressive.
But every cancer has its own staging in the sense, a lot of them use that TNM, where they look at the tumor, they look at the nodes, they look at the metastasis.
Yeah.
But the requirements for one are different than another cancer, so a very tiny, so a small tumor in one cancer may be a T1, and another it may be a T2, the
Okay.
same size tumor. But then they do look at what it looks like. Does go into the staging somewhat, but the grading is probably less used than staging.
I'd say staging as well.
Because you need a stage, because you have to know how to treat it based on the
But
stage.
they usually do both?
They often do, yeah. Because as the pathologist looks at it, they'll say, oh, this is a high grade, meaning it's not that well differentiated. Or they don't always use the word grade. If you read it in Pathwart, they
Right.
may use, well, this is well differentiated.
Mhm.
They may not give it a
Which
grading.
means it's
I was gonna say, I hear more of this than I do
Yeah.
the grading.
So
Yeah.
it means it looks very similar
To the normal tissue.
cell.
Yeah.
Mhm. Yep.
Does that make it less?
Usually-
Say you have a
usually- yeah.
stage 3, but a grade 1.
It's better than a stage 3 grade 3.
Right.
Usually, yeah.
Okay.
Yeah.
It does, it gets complicated too. It can get very complicated.
And it only gets more and more complicated as they're doing more and more tests and looking
Yeah.
at different things.
Okay.
But yeah, in general, the higher the stage and the higher the grade, the worse prognosis.
But you can have disparity between the two.
Oh, yeah,
Mhm.
yeah, you could have a
Mhm.
stage 1 and a grade 3 or even a grade 4. But it just, because the stage 1 just primarily tells you it was caught early.
Right.
And it hasn't spread anywhere.
But does that mean it's probably a faster growing cancer?
It's gonna
It
probably
could- yeah.
it's probably more aggressive,
Okay.
yeah,
But you caught it early enough, which is better.
yeah.
Yeah. Okay.
This is more about the cell kinetic growth and division, the functional changes. Greater the degree of differentiation, more likely will have some functional capabilities. More anaplastic, less likely is that any specialized function is present. The cell cycle time is the amount of time required for cell to move from one mitosis to another. It varies in the type of the cell, each cell is different. Misconception is that tumor cells proliferation is faster than normal cell. Actually, it's the same rate as tissue of origin. Difference is proliferation is continuous. Kind of like we were saying, like normally it would stop.
It only does it
This
when it
just
needs
keeps
it, yeah.
going, yeah. Length of GO phase is major factor in determining cell cycle time. The tumor growth patterns, the hypertrophy increases in cell size, increases organ size, means there's an increase of workload for the organ. Hormonal stimulation. Hyperplasia, reversible increase in number of cells in organ and tissue in response to specific stimulus. Metaplasia, conversion of one cell type to another cell type, not usually found in the tissue. This is induced by inflammation, vitamin deficiencies, chronic irritation, chemical agents. Dysplasia, abnormal changes in size, shape, or organizational of cells. Stimulus usually external from radiation, inflammation, toxic chemicals, chronic irritation. Carcinogenic factors, hereditary, like we talked about, the hormonal regulators of growth, exposure to physical carcinogens. As we said, like the radiation, asbestos, ultraviolet radiation. Oops. This is about the oncogenetic viruses, the DNA, Epstein-Barr, herpes virus, Burkitt's lymphoma, B-cell lymphoma, hepatitis B, hepatitis C. There's RNA, the human T-cell leukemia virus, type 1, from T-cell leukemia. These are things that you'll probably hear a little bit of, like the leukemia, the T-cell leukemia and stuff like that on the BMT unit. Carcinogenic factors, bacteria and parasites, Helicobacter pylori, gastric lymphoma. A lot of these I'm not real familiar with, to be honest with you. The Opisthochorus, I can't say it. Anyways, another parasite. Immune system deficiencies, the tumor cell camouflage, antigen modulation, overwhelming antigen exposure, and blocking agents. So, how can we prevent cancer? You know, we hear about all this cancer, and what can we do? What can we do to help ourselves to prevent? How can we go out into the community and help educate individuals out there? What we want to do, there's some cancer prevention recommendations. Obviously, no smoking, quit smoking, maintain a healthy weight, exercise, be active as possible, eat less salt, enjoy a plant-based diet, eat well. Everything is obviously in moderation. And try to cut back on exposures to radiation, to chemicals. It's hard in today's society, to be honest with you, with all the things that we're exposed to. Even the food processing. You know, I know a lot of people try to go to organic and it's expensive, but even the food we eat. I know working up on BMT, we saw a lot of paid farmers. The stuff that they would put on the lands. So we're exposed to a lot, and just trying to help maintain our environment and a healthy environment is a huge help. There are screens that are available. I know you're saying about your sister. They'll probably recommend you getting earlier mammograms. Earlier detection of cancer may lead to better outcomes. They did try to increase like the, what am I trying to think, for colon cancer, the colonoscopies. I don't know if they changed the age or not. I know there was some talk about trying to change up the screening at an earlier age. But colon cancer screening, mammograms, pap smears, prostate screening, genetic screening. As nurses, I feel like we need to go out and more into the community. People aren't aware of all these things. I mean, they might hear about it, but they don't do it. They don't realize the importance of eating healthy, of getting screened, going to your GYN, getting your inspections, seeing your primary care doctor. These are all